So one other logistic point about managing toxicity. So you brought up the ocular toxicity.
Yeah.
How big of, I guess, a practice management step will that be in your practice? Do you envision your ocular colleagues having to be involved in all of your patients?
No. I mean, the truth is no.
Yeah.
Again, the ocular toxicities associated with camizestrant, they're not structural. They are symptomatic, and they're not functionally impairing. And to really know, I think it's not going to require, for example, having an MD provider,
Right.
an ophthalmologist.
Right.
If a patient has some changes, they can see an ophthalmologist, they could see an optometrist, but
Right.
the reality is it's very different than some of the other agents we're using. When we, and this isn't breast world, but for those of us who dabble in other disease types, you use mirvetuximab. You cannot miss an ophthalmic exam on that drug, or you can cause real damage to that eye. You can cause real damage to a patient's vision, and that's not necessarily something that recovers quickly.
Right.
So there's a different type of ocular management, surveillance, and toxicity understanding that comes with other agents in oncology, and that should not be confused in my mind with what we're talking about with camizestrant.
Yeah, that's perfect.
Yeah.
I think our comfort level with it will evolve as it has for
Yeah.
so many of our agents. But I think giving that reassurance to patients,
Yeah.
that it is not structural,
No.
that it will resolve, that most patients
Yeah.
just adjust to it, and it shouldn't have functional
Right.
consequences.
So in many of our regions that are underserved, where we don't have easy access to an ophthalmologist for our patients, I don't think it's going to be an issue with this drug.
Right. It
in the
wouldn't
way
limit
is for others.
utilization.
Correct.
Yeah.